Hi there, my name is Elizabeth Mundell, and I am a movement disorders neurologist at MedStar Georgetown University Hospital. I'm very excited to be here today to be part of this wonderful series covering advanced therapeutics in Parkinson's disease. Today, we are going to go beyond the ninth hole and talk about on-demand therapies for Parkinson's patients experiencing off episodes. Let's start by talking about how to change the current treatment paradigm. First, we have patients who are diagnosed with Parkinson's disease. And generally, soon after patients are diagnosed with Parkinson's disease, they're started on oral carbidopa levodopa. We know that this can be helpful both therapeutically and diagnostically, can help to improve their symptoms and show us that they have a robust response to the medication, which we expect to see in a Parkinson's disease diagnosis. Soon after, patients begin to experience what is known as off episodes. And when patients have off episodes, the traditional model is to either increase a patient's carbidopa levodopa, have them take it more frequently, or add the usual on extenders or medications that are adjunctive therapies to help a daily maintenance regimen increase their on time throughout the day. Off episodes are common with traditional anti-Parkinsonian regimens. We know that off episodes are estimated to have a prevalence of 25 to 50% within a period of 2 to 6 years of initiating carbidopa levodopa treatment. So this is a very, very common problem. Here we'll look at a pilot study that looked at 151 patients with Parkinson's disease that were on stable doses of levodopa, and 64% of them reported experiencing motor fluctuations. They defined stable doses of levodopa as being on a stable regimen for greater than or equal to 4 weeks. And you can see in the bottom pie chart here in the center that 64% of the patients who had off episodes are represented in blue. The mean disease duration was 7.6 years. And when you take just the patients who were having motor fluctuations in the blue section and look over to the right, what you can see is that the disease duration has actually increased. So for patients who did not have motor fluctuations, the average disease duration was 6.6 years, and with motor fluctuations, 8.1 years. So we know that the prevalence increases as time goes on, that you're more likely to have motor fluctuations as time goes on. And for those patients in the blue chart that do have motor fluctuations, you can see that they're overwhelmingly already on the typical extender medications or the typical adjunctive medications. They're on dopamine agonists, COMT inhibitors, and MAOB inhibitors, but they're still having fluctuations despite the use of adjunctive medications. So this is another way to look at the impact of off episodes. Here, Parkinson's disease patients reported between 3.2 and 7 hours of off time per day, which is dramatic, 7.7 hours of off time per day. And what you can see in the graph is the effect of all of the traditional modifications to the daily regimen to try to decrease off time. So the top box here, the box that's in gray, shows an adjustment of levodopa alone. And below the gray box are the various adjunctive medications and their effect on off-time reduction. So a patient with no adjustment had the 3.2 to 7 hours of off-time per day with no adjustment to medications. And then you can see with some baseline adjustment to medications, the off-time reduction ranged from 0.6 hours of off-time in the amantadine extended release group up to 3.2 hour reduction in the tolcapone group. And we don't even use that medication here anymore. So overall, what this is trying to show is that despite using other extenders to carbidopa levodopa, off time still exists and is still a big problem. So that takes us to the on-demand therapies. On-demand therapies are available to manage up to 5 off episodes per day. And we have three on-demand therapies that we're going to talk about today in more detail. The first is the apomorphine injectable, which was approved in 2004. And the dosing for this drug is 2 to 6 milligrams per off period on demand up to 5 times a day with a maximum dose of 20 milligrams per day. The second is the levodopa inhalation powder, which was approved in 2018 for a maximum of 84 milligrams per dose per off period, up to 5 times a day for a maximum total of 420 milligrams in a day. And the third is the apomorphine sublingual film, which was approved in 2020 at a dose range of 10 to 30 milligrams per off period and can be used on demand, again, up to 5 times per day. So we'll take a look at the first on-demand therapy, the subcutaneous apomorphine. This drug was shown to have a very rapid off-period rescue, even within 10 minutes, so 10 to 20 minutes, which is why this drug is still used commonly, despite the fact that many patients, understandably, could be hesitant to use a subcutaneous injection. The pen system comes in 2 to 10 milligrams. It's very easy to use and treats very effectively unpredictable, frequent motor fluctuations. Because of the fact that patients are not going to be too excited about having to use an injectable, there have also been trials that have been ongoing to look at a continuous subcutaneous infusion pump, similar to an insulin pump. But this is still in the clinical trial phase and is not FDA approved, though it continues to be studied. Side effects of apomorphine included nausea, vomiting, and hypotension, similar side effects that you would expect with a dopamine agonist. Originally, people were using trimethylbenzamide as an antiemetic, but that's no longer available, though most patients are tolerating this medication without any sort of antiemetic necessary. Next, we'll talk about the inhaled levodopa option. This is used on demand for treatment of off periods or the return of Parkinson's symptoms. It's indicated up to 5 times a day. And what's unique about this delivery system is that it has a pulmonary delivery, so it really bypasses the gut completely. It improves off symptoms as soon as 10 minutes and can last for up to 60 minutes. We'll talk about that in a little more detail in just a minute. But you can see here the trial design that looked at the inhaled levodopa, which was a placebo group, an arm of 60 milligrams of inhaled levodopa, and an arm of 84 milligrams of levodopa from week 0 to 12. Here, what we see is the data from the pivotal trial using inhaled levodopa. The primary endpoint for this trial was the difference in UPDRS motor score after 30 minutes of using inhaled levodopa. And the results showed that the UPDRS changed by 9.83 points in the treatment group, the patients who received inhaled levodopa, compared to 5.91 points in a placebo group. So on the graph, you can see both how quickly the inhaled levodopa starts to work and that the treatment benefit is sustained. So the green line here shows the 60 milligram treatment group, and the blue line shows the 84 milligram treatment group. So we can see that there's a dose-dependent response. The 84 milligram group had a more significant reduction in their symptoms. Like I said, the treatment benefit was as soon as 10 minutes and up to 60 minutes. And we know that this is safe and well tolerated. In fact, when they looked at the adverse events, there were 7 patients in the 60 milligram group that reported adverse effects versus 5 patients in the 84 milligram group. Next, we'll talk about sublingual apomorphine. This is our third on-demand therapy. And you can see the sublingual strips are truly strips that are placed under the tongue. And the picture on the top right will show you that. It comes in 5 different strengths that are titrated to find which strength can help your patient break from an off episode. The primary endpoint in this study also looked at the change in UPDRS motor score at week 12, 30 minutes after administration. And the results were dramatic. The results showed an 11.1 point change in the UPDRS motor score compared to a change of 3.5 points in the placebo. So the top graph in the right, you see On the right, you see that the placebo group is in red and the treatment group is in blue. And again, you see a rapid onset of medication working, working quickly, starting at just 15 minutes. And this is sustained even 90 minutes after the dose. And the second graph below, you see longevity data. You see the ongoing improvement in patients using sublingual apomorphine, even at week 12. The side effect profile is also very mild. Mild to moderate oropharyngeal events were the most common side effect reported in 17 of the 54 patients receiving apomorphine sublingual film. Other adverse effects were similar to the sub-Q apomorphine, including nausea, somnolence, and dizziness. So on-demand therapies are definitely efficacious and generally well tolerated to manage off episodes. Just a little review here. We have the apomorphine injection, which works 20 minutes after the dose and had the most dramatic change in the UPDRS motor score, 23.9 point reduction compared to 0.1 in the placebo group. And the mean dose of the active drug necessary was 5.4 milligrams. For the levodopa inhalation powder, we know that the primary endpoint they were looking at was 30 minutes after the dose of the UPDRS motor score at week 12. And this one showed a reduction of 9.8 points compared to 5.9 in the placebo group. And apomorphine sublingual film, again, was looked 30 minutes after the dose at week 12, and there was a reduction in UPDRS motor score of 11.1 points compared to 3.5 in the placebo group. What's different about all of these medications is that they have adverse effects that are specific to their route of administration. So for the sub-Q injection site reactions were present. For the inhalation powder, most commonly patients report a dry cough or some upper respiratory infection or sputum discoloration. And for the sublingual film of apomorphine, the oral adverse events were present. We know that oral carbidopa levodopa can be associated with off episodes due to GI tract limitations that are present in Parkinson's disease. Dysphagia is a very common problem, and we know that dietary protein can interfere with levodopa absorption. This is why we counsel all of our patients to separate their levodopa from the intake of protein by at least 30 minutes. Gastroparesis can also decrease levodopa levels, and gastroparesis can delay the peak dose of levodopa. So this graph here shows the extreme variability of the pharmacokinetic information after one dose of carbidopa levodopa. And what's striking here is that it's all over the place. Nothing is consistent here. You can see that from person to person and from even within one person, from time to time that they're taking a dose of their oral carbidopa levodopa, their response can vary so much because the plasma concentrations vary so much due to the GI limitations. We talk a lot about constipation in Parkinson's. It's one of the first symptoms that may emerge even before the motor symptoms of Parkinson's. And we counsel our patients a lot about treatment of constipation. But what we know is that GI dysfunction is really present throughout the entire GI system. Both lower and upper GI dysfunction are present. The whole route is pretty dysfunctional. And we know that there are alpha-synuclein deposits, not just in the intestines, but all the way up even here to the submandibular glands. What this picture is showing is an actual picture from an endoscopy where there are two pills stuck to the gastric lining. So this is a person who, let's just say, was adherent to their medications, taking their carbidopa levodopa on time. And we know that the carbidopa levodopa is absorbed in the small intestine, but it's not getting where it needs to go because of an absorption issue in Parkinson's. And that can lead to a very variable and unpredictable response for patients, which can negatively impact their quality of life. We know that delayed on is also a therapeutic problem despite the use of on extenders. And this is a reminder that off time includes not just the actual off time, but the time that it actually takes to reach a therapeutic threshold, which is really, it's eye-opening to see how narrow the therapeutic window can be for someone taking carbidopa levodopa. Here is data from a study of patients with advancing Parkinson's disease. The mean time to on after they took a pill was 46 minutes. Like, wow, that's someone who is not feeling well, is in an off state, take their medication, and they still have to wait 46 minutes until they fully are in the on state. And then, let's say they have a good period for a period of time. Once they start wearing off, it can take 21 minutes to get to rock bottom. But that 21-minute period is another suboptimal period for a Parkinson's patient. So there's a very narrow therapeutic window. We know that the delayed on is often primarily problematic in the morning and important to address for patients. Concerning their morning dose in the past week, 51% of patients reported a delayed on at least once, and 21% reported delayed on every single morning. 56% reported that it took over 30 minutes in duration to turn on after the morning dose. And this may be due to the fact that they've totally worn off of their medication overnight, and the fact that they've been more sedentary and more stiff. But they need to have their medication so that they can do things. The simple things that we take for granted, getting up in the morning, getting dressed, going to the bathroom to start your day. This is very, very difficult for a patient because of the delayed on effect in the morning. So I bring this up to show that pharmacokinetic properties definitely support the use of on-demand therapies, especially because they have a different route of administration other than the GI tract. We know that the Tmax of on-demand therapies is about half of the Tmax of oral carbidopa levodopa and other oral on extender medications. And this is because they have a way to bypass the GI tract, which is often so significantly affected in our Parkinson's patients. And also, patients don't have to worry about dietary considerations when they're using an on-demand therapy. So this graph here this chart here is another representation of the typical carbidopa levodopa and on extender medications. The fact that they take time to kick in. Carbidopa levodopa perhaps the soonest at 30 minutes, but can take hours to kick in. And the on-demand therapies can take as soon as 10 minutes to kick in. And the fact here that food has such an effect on absorption of these medications that often patients have a delayed on, and also they need to adjust their food intake around these medications. But when you look at the on-demand therapy class, there's no food effect, and the fast, rapid response is reliable. So I wanted to take a step back and discuss the many different forms of off periods in Parkinson's disease and potential targets for patients using on-demand therapies. So we talked a little bit about the morning off, which is the symptoms Parkinson's patients experience in the morning before their first dose of carbidopa levodopa for the day. We talked about a delayed on, and that prolongation in the time it takes for a therapeutic dose of carbidopa levodopa to begin alleviating symptoms, more frequently after the first dose of the day or after eating, but can be common throughout the day as well. We talked about wearing off, a decline in the benefit of treatment, deteriorating at a time when they're having sort of a suboptimal dose. They're wearing off, although they're not completely off yet. And sudden offs are those potentially random transitions from on to off. Those are very unpredictable and really impact the quality of life for patients because they can't plan what they're going to do for the day because they're afraid that they're going to suddenly have an off period that keeps them potentially frozen. And dose failures when therapeutic doses of carbidopa levodopa don't work, even though the patient's doing everything right. Perhaps it is the GI system that's keeping a particular dose from working properly. And these are the proposed patterns and mechanisms for wearing off. So The clinical pattern of wearing off is thought to be due to the relatively short half-life of levodopa, which is our maintenance therapy, and also due to a presynaptic storage issue with dopamine. Delayed on has to do with an issue with gastric emptying and a problem with intestinal absorption. Same with no on at all, an issue with either gastric emptying, intestinal absorption issues, or an issue with the blood-brain barrier transport system, or a random on-off period, no predictability at all. And that's what we talked about with the very unpredictable pharmacodynamics of carbidopa-levodopa. When we talk about on extenders, there are several risks associated with them too. We know that on extenders have the potential to worsen dyskinesia and increase the side effect profile of all of the medications they're taking. Looking at levodopa alone, increasing the dose of levodopa can cause dyskinesia, and increasing the frequency of levodopa can require that a patient delays meals or manipulates their meals, potentially leading to unintended weight loss. I think also increasing the frequency of levodopa can cause dyskinesia as well. And then if someone opts to leave the levodopa alone, but add a typical on extender to manage the off episodes in addition to levodopa, again, we have the potential to exacerbate dyskinesia or worsen the side effect profile of their other dopaminergic therapy. For example, lead to more somnolence, but a peak dose sedation is a very common thing that patients will report. Impulse control disorders, especially with our dopamine agonist class of medications, and certainly hallucinations or psychotic behavior can be present when we're increasing the amount of dopamine a patient is taking. And I think also we're increasing the overall complexity of the treatment regimen when we're adding more and more medications that patients have to take every day at a specific time. That gets very hard to do. So because of that, the on extenders can be associated with non-adherence. We know that when treatment changes are made that add new therapies and add complexity, it gets frustrating and can increase non-adherence. Over half of patients with Parkinson's take at least 2 anti-Parkinsonian drugs, in addition to multiple other prescriptions for all of their other medical conditions in this patient population. These are generally elderly patients with lots of other comorbidities as well. And we talk about using a cocktail of medications for Parkinson's to really improve their overall treatment regimen. Compared with people who don't take their medications as prescribed, we know that non-adherers have higher rates of hospitalizations, office visits, other visits to other doctors too, and this increases medical costs greatly. Pill burden is high in Parkinson's patients, and new therapies are expensive. We have a big adherence problem as we're increasing combination therapies for patients. So let's change the current treatment paradigm. We talked about today how carbidopa-levodopa and the on extenders have a limited effect on decreasing daily off time. Off time is still a problem despite our regular maintenance medications day to day. When we add on extenders, we run the risk of worsening dyskinesias and increasing other adverse effects. And ultimately, this can be associated with non-adherence and increased medical costs in the people who are not adhering to their regimen properly. We know that on-demand therapies are both efficacious and well tolerated for managing off episodes. And the pharmacokinetic properties of these drugs further support the use of on-demand therapies, specifically the fact that they can bypass the gut, bypass the GI system that we know is not functioning well in Parkinson's patients, and they work much more quickly and reliably because of that. We also don't have to tell patients to change their diet or worry about what time of day it is before they're using that medication. So in summary, clinical research data suggests that even adding more extenders to our carbidopa-levodopa, patients are still going to have off periods that they experience frequently. I think about this sort of like our headache colleagues. When they treat migraines, they use both prophylactic maintenance medications, and then patients have an on demand medication to take in case they have a breakthrough migraine, something that they have a tool in their pocket to use to treat their symptoms when they break through their maintenance medication. I think on demand therapies should certainly be offered sooner to our patients who are experiencing off episodes, which is the vast majority of our patients. Patients really appreciate having a tool on their own to take control of their own off episodes. I think this also reduces anxiety to know that they have some sort of trick up their sleeve to get them through some unpredictable off period. And overall, therefore, the on demand therapies can significantly improve a patient's quality of life. I hope that this presentation was informative, and I hope that you all have a great rest of your day.